Hi there, my name's Bryce Walker. I'm a second year at the Spokane campus for University of Washington School of Medicine. My summer I project was based around a learning software which is used for radiation planning treatment. I worked with Dr. Afui York and Dr. Ralph Morian from their base at Seattle Children's. Take a look at pediatric patients, mostly with medulloblastoma. The long-term goal of this project is to find simple ways to position pediatric patients so they will receive less stray radiation dosage to important tissues like the ocular lens, the ovaries, and the uterus, especially in young females. So we'll talk about the future of this project near the end, but I want to begin with an introduction on therapeutic radiation technology and how it works. And before that, I just want to talk about medulloblastoma. So that's the main thing we can look at as a study subject in pediatric radiation oncology because it actually accounts for nearly 25% of all pediatric brain tumors. It can present throughout the central nervous system, so radiation oncologists typically attempt to concentrate radiotherapy to the brain and the spinal column, and that's what we call craniospinal irradiation, or CSI, in this poster here. So patients are taken for a preliminary CT scan, sometimes an MRI. The scan will be viewed in a software, in this case on Citrix, called RayStation. Radiation oncologists will plan their treatment through that from that preliminary CT scan. And then when they return for radiotherapy, they'll be placed in the exact same position for treatment. So it helps to understand how radiotherapy works, to understand the secondary problems that can come with treatment. It's based around a machine called a linear accelerator, which will send free electrons through an electric field. They'll be bent by a magnet. Before reaching the patient, all these high energy electrons will encounter a multi-leaf collimator, which is like an adjustable tungsten aperture, and that helps shape the beam in a number of different formations before it reaches the patient. We can also move the couch. We can rotate this large gantry, and that gives you a number of different positions for treatment. You can position the patient on the couch, and this gantry can come at a number of angles to the patient. So this all helps target our dose to the lesion that we're trying to irradiate, but with photon radiation, the beam will always pass through the target lesion and to anatomical structures beyond that lesion. So this concept is especially important when we're talking about craniospinal irradiation, because when we're talking about radiating the brain and the spine, you could understand that a number of important structures might receive a dose of radiation that can be detrimental to the function of that tissue. So like I said previously, one example is the ocular lens. And we know that doses of radiation to the ocular lens can present an early cataract in pediatric patients. And obviously, radiation dosage to the ovaries and the uterus in a pediatric patient are prone to damage as well. There's good literature that suggests a dosage of less than 5 gray, that's our measurement for radiation, is in gray. So a dosage of less than 5 gray can cause sterilization to otherwise healthy ovarian tissue. So for our future project, there's a number of small variations in patient positioning that might make a difference in stray radiation dosage. One plan is to have our patients gaze upward while they receive their radiotherapy. And the idea behind this would be that they can encounter their ocular lens will encounter less radiation dosage. Simple options may also exist to avoid stray radiation dosage to the ovaries and uterus. One topic that we want to investigate further in the future is how much radiation dosage can be avoided by having patients just empty their bladder before treatment. So all these simple changes in positioning could make a difference in treatment as far as secondary malignancies from the radiotherapy, and that can make a large difference for pediatric patients down the road. And that's what makes them really important to look into. They can also be studied retroactively, which is nice through the software. And we can do that just by using our radiation planning software and changing the patient positioning to see how it would look in theory with patients simply gazing up, for instance, or emptying their bladder. And then we can take a look at radiation dosages in any point of interest. So that would be like the ovarian tissue, the uterus, or the ocular lens. So to end out, we do want to talk about just limitations of photon radiation. So like we discussed before, there's obvious limitations because that photon radiation will pass through our target lesion and into healthy tissue. There's also just unavoidable variabilities in radiotherapy with repositioning patients from how they were in their planning scan. Getting it exactly right can be difficult. Even breathing, filling the bladder, just regular bodily functions can change patient positioning that you can't really plan around. And more stray radiation dosage can go into healthy tissue that wasn't planned out. So trying to limit this stray dosage is, however possible, it's really important and of great benefit to our patients and adult patients in a lot of cases that are undergoing radiotherapy. And so lastly, I wanted to touch on proton beam therapy, which is a very interesting topic for future discussion. Unlike photon beam radiation, which is what we've been talking about, so photon beam radiation uses high energy electrons, sort of like a high energy X-ray. Proton therapy uses charged ions, which can be carried directly to the targeted lesion with little or no exit dose beyond the lesion. So this is all kind of an interesting topic, and it's based around a physical concept called a Bragg peak that anyone interested in radiation oncology should look into. It's just an interesting topic. Currently, photon radiation that we've been talking about here, that remains the standard of care. Randomized control trials show no differences in treatment between proton and photon radiation as far as overall survival or treatment failure rates. Additionally, proton radiation requires much larger particle accelerators, can take a good chunk of a building, and it's financially unfeasible for a lot of hospitals. But if you're interested in radiation oncology, I'd highly advise looking into a research project like this or learning more about photon or proton therapy. It's certainly a changing field. It'll be interesting to see how treatment will evolve over time. So thank you. And again, my name is Bryce Walker. I hope you learned something today, or at least I gave you some interest. Have a great day. Thank you.